All right, good afternoon or morning, everyone, depending on your time zone, and welcome to today's webinar entitled Updated COVID-19 Billing Guidelines for Hospitals and Physicians. We appreciate you taking time out of your busy schedules to join us for today's web session. I do want to mention, we originally scheduled this session for approximately 30 to 45 minutes, but due to the amount of new content, as well as the many questions we are anticipating being submitted throughout the session, we will most likely extend the length of today's session to at least 60 minutes. We want to make sure we get through all of the content, and we also want to make sure that we do our very best to answer questions as they come in. So before we begin, let's cover a few housekeeping items. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. We may not get to all of the questions live, but we will be providing everyone on today's session with an FAQ document that includes all the questions and answers received throughout today's session, as well as the PowerPoint that we're presenting today, and a link to the live recording. You will get all of that within 5 business days via email. Today's presenters are Jennifer Bishop, Vice President of Content, and Ardith Campbell, Content Product Manager here at Vitalware. Jennifer, the show is yours. You now have the floor.
All right, I am going to take it away then. It's probably a good thing you can't answer me, because the first thing I would ask is, who in the world is tired of hearing from me on this? I know I'm tired. Sometimes it's getting hard to keep talking about this, but the information just keeps changing so quickly that we want to make sure that we're keeping you guys up to date. So my usual disclaimer, this is current right now. It may not be current this afternoon, but we will keep you updated on anything. All right, so let's get started. I'm going to start with some outpatient hospital coding guidelines, move into some inpatient hospital reimbursement and things, and then I'm going to turn it over to Ardith to talk more from a physician point of view. So I've kind of structured this a little bit on the things that I am getting a lot of questions about. And the first thing is the specimen collection. And CMS has been a little bit wishy-washy about this so far. So this is our best advice at the current time. If you have a patient who comes in and has an E&M visit, they're worked up, and during the course of that, they're tested for COVID-19, we have a code of, primarily what you're going to be using would be the G2023 then, because this is presuming that they're coming to you, which is specimen collection. There's also a G2024, which is if you're obtaining that during the course of care for a SNF patient or on behalf of a home health. Both of these codes have a status indicator of N when we're talking about the OPPS, which means they are packaged, no reimbursement. Both of them have an effective date of March 1st. So we're going to talk a little bit about that, because that's going to present some challenges, that status indicator of N. Because what happens in our scenario number 2, where maybe your facility is acting as a drive-through clinic for testing, and all you're doing is collecting the specimen, there's no E&M, you're getting the specimen, you're sending it to the lab, and that's all you're doing for the patient. This is where we've got some problems right now, because if that's the only thing that you're doing for the patient and you try and submit that G code, and that's the only thing you're doing, it's got a status indicator of N, which means it's packaged into other procedures. If there are no other procedures, you're going to get a claim rejection on that, because you can't just submit status indicator N on a claim. So the recommendation from the AMA, and this is not coming from CMS, is to assign a low-level clinic visit when the only thing you're doing is specimen collection. So we have questions out there to CMS about this. As soon as we get any kind of update on this, we will let you know. All right, so as far as testing for detecting the COVID-19 virus, not the antibodies to the virus, but the virus itself, we have several codes. So these they are new, but they're not new anymore at this point. We have 3 of them, 2 from CMS U codes and 1 from the AMA. I put together a little table here, and this was actually in the last presentation as far as what the reimbursement is, when you would use these. So basically U0001 is used for the CDC lab tests. Not sure how many of those are happening anymore, but that has a lower reimbursement than the other 2. So if you are collecting the test and you're using CDC test kits and it's going to them, that's your code. The other 2 are fairly similar codes there. The difference being that one was developed by the AMA, one was developed by CMS. The reimbursement is very similar. The effective dates are slightly different. CMS has provided guidance on this, saying that the 87635 should be assigned when you're actually doing this amplified probe technique, the one that actually is described by this. If you're doing any other sort of testing, that's what the U0002 would be used for. Every insurance I've come across, including CMS, all payers are basically accepting either one of these with comparable payment rates. But of course, I can't guarantee that. You'd have to check with each payer to make sure that that is the case. We also have 2 newer codes, which if you're looking at them, have monster descriptions, but essentially U0003 has the exact same description as 87635, and U004 has the exact same description as U002, except for this part that I added the underline there, which is making use of high throughput technologies as described by the CMS special ruling that was just published. All right, so what does that mean exactly? These codes are to be used when you're actually using high throughput technologies that deliver these test results a whole lot faster. So CMS did list in their special ruling what some of those are. It's not an exclusive list, but these would be like the Roche Cobas 6800 system or 8800. There's an Abbott system, M2000. There's a Hologic Panther fusion system, a Gene Expert Infinity system, and a new, I don't even know how to say it, new MoDX 288 molecular system. So the intent there is that those actually take a little bit more effort to do and cost a little bit more, and therefore the reimbursement rate is higher with those if you're using those technologies. Note that both of these codes are effective April 14th, which was the day that the special ruling was released. They are not retroactive, and CMS has verified that a couple of times. They are not retroactive. Okay, then we come to the new tests that were created by the AMA for antibody detection. So this doesn't tell you if you've got, well, it could tell you if you have the infection currently, but it also tells you if you've ever been exposed to the infection. That's primarily what that one's used for. So we have 2 new codes there from the AMA that are sort of similar there. And we're going to look at the differences here on the next screen. Basically, 86328 is a single-step component, single-step testing. That's what you use if you've got a strip that already contains all the components for antibody testing. It's going to be reported once per strip assay, and it really doesn't matter how many different immunoglobulin classes you perform as long as it's a single strip. I don't know if they do yet or if they're anticipating that a single strip could test for multiple IG classes. But anyway, that's 1 per. We don't yet have any reimbursement on these, but both of these codes are effective April 10th, and again, not retroactive. 86769 is for use when you are performing a multi-step test, and that one is actually reported once for each immunoglobulin class that is tested. Again, no reimbursement and same effective date there. All right, so that's pulling us out of lab testing. Let's talk about telehealth. This is another one that I probably just should have put big question marks all over the place because this is going to change. But right now, at this particular moment, there is no facility fee for telehealth services at the current time. And CMS's rationale for that is the fact that the facility fee was supposed to compensate facilities for their supplies, their equipment, the use of their physical space. If that's not happening right now because the patient is remote, CMS didn't feel like any payment was needed. Now, they've heard from a lot of providers that that's not the case, that there are costs associated with the facility providing the telehealth visit even to a remote patient when the physician's in their facility using their stuff. Okay. So right now, though, that is what it is. We expect that to change really shortly, and we'll update this again as soon as it does. So I put together just a couple of scenarios here, which is, again, at the current time. So in this scenario, the physician is in the hospital, and he's providing the telehealth services to the patient at home or a remote site. And in that case, there is no facility fee. The physician's going to bill for his telehealth services and receive that reimbursement. And Ardith, like I said, we'll go into more of that later when she covers that part. Scenario number 2 is the physician is located at his home or off-site from the facility and is providing telehealth services to a patient that is physically located in the hospital. In that case, you can charge for the telehealth originating site facility fee with that Q3014. All right, let's talk about inpatient reimbursement because there has been a development in this since the last time we did this. So the MS-DRG grouping has not changed, and neither technically have those DRG rates over here. But what has changed is there is now a 20% weighting factor adjustment for the COVID-19 cases during the course of this public health emergency. Okay. The adjustment is going to be made automatically by the MAC, so you don't have to resubmit anything. You don't have to ask for this to be done. It is supposed to be happening automatically. Of course, I would verify that personally. I'm not sure. You would have to check with your MAC to see what their time frame is for doing this. But basically, any account that has, it's going to be identified by diagnosis code. So if you submitted a discharge between January 27th and March 31st using B9729, that will qualify for the adjustment. And on or after discharges on or after April 1st, it will be identified with that U07.1 diagnosis code. And that will continue through the end of the public health emergency. So, of course, we don't have an end date on that yet. I wish I could say we did, but not yet. Just wanted everyone to be aware, again, that your entire stay is going to be counted. So even if you have a patient who no longer medically needs to be in the hospital, but you can't find an appropriate place to put them, or they still need to be quarantined to avoid affecting other individuals, you can continue to submit those charges to Medicare, and they will be looking to cover all that. All of that's going to go into your outlier care if it gets to that point. No differential for a private room, and there is a current waiver on the 3-day prior hospitalization rule for coverage of a SNF stay. So they don't have to have that 3 days of inpatient stay in order to be released to a SNF and have that covered. All right, I am not going to go ad nauseum through all of these flexibilities. I wanted you to be aware of them. But CMS has put an awful lot of flexibilities into place as far as the hospital without rules, without walls, not without rules, that covers temporary expansion sites, off-site locations, all of that kind of stuff. Excluded distinct part units, that's kind of been blurred at this point. You don't have to keep those separate anymore. Make sure anytime you're providing care under any of these flexibilities that you are documenting why there's a need for that. There's flexibilities for the critical access hospitals, waiver of length of stay, rural requirements, provisions related to telemedicine for care of patients in the hospital, and there's a whole lot more, again, that Ardith will get into. There's some flexibilities over authentication of verbal orders, not that they don't ever have to be authenticated, but there's some relaxation of time limits. Discharge planning is not nearly, the requirements are not nearly as rigorous anymore. They want to make sure that you're spending your time caring for patients rather than worrying about discharge planning and writing down everything. There's flexibility in the completion of medical records, waiver of making sure that that you're asking everyone about advanced directives. Some other waivers on quality reporting that you guys are probably already aware of. Nursing plan requirements, all of that stuff has been relaxed during the current PHE. Cost reporting, hopefully none of you have to deal with that, but that's all been, deadlines for that have all been extended. Some waivers as far as equipment, reuse, that kind of stuff. As again, more on the physician side, but if physicians if their privileges are about to expire, they can continue to practice right now. There's some flexibilities under who can be the attending provider. It can now be physician's assistant, nurse practitioners. All of that. There are lots and lots more. So if you guys have any questions about that, we'd be happy to answer that at the end. And I am now going to turn this over to Ardith. She's got all of the good information. So
okay, and then you're still driving for me though, Jennifer?
I plan on it, yes.
Okay.
I like to drive.
All right. So let's go ahead and go to the next slide. Again, now the condition code, of course, is going to be for your facility claims, but when all items on your claim are disaster related, you apply the condition code DR. Now, modifier CR is your catastrophe or disaster related, and that's used by both outpatient hospitals and physicians, and that is for individual line items that are related to the PHE. Now, our friend modifier CS, which is for the cost sharing for specified COVID-19 testing, this is used to indicate that the cost sharing for those items should be waived. All right, so the next slide, Jennifer. So, so it should be applied to your medical visit that prompts the ordering of the COVID-19 lab. And the guidance is for services furnished on March 18th and after through the end of the PHE. You should use that CS modifier on applicable claim line items. And this has been the subject of many questions, and CMS has waffled back and forth and has stated that more guidance is to be issued because there's not a lot out there. The regulation states that it's for items and services, and so it is for the evaluation and management and for the lab test. Now, the lab test that would only be if there is a coinsurance amount related. So if the patient has not yet met their deductible, they should also have that CS modifier added as well. The other where some of confusion comes in is for the items and services. So there's been no guidance yet to say, okay, what if we have a chest x-ray? What if we have some other blood work done? Do those items also get the CS modifier? And unfortunately, at that point, CMS has said, we're taking these all into consideration. We don't know, and we will issue more guidance. So unfortunately, we do know that it should be applied to the office and other outpatient services, your observation, ED, nursing facility, and all of those, even if it's online. Those are covered and should get the CS modifier. But beyond that, the lab test is kind of a crapshoot. It depends on whether the payer has a coinsurance amount for the lab, which most don't, and whether the deductible is met or not. So, and that is also a crapshoot as well, because unless you're checking that ahead of time, you won't know. All right. So some of the other flexibilities that we have for Stark, that CMS is given for physician, has to do with your Stark law waivers. So that means any of your self-referral to anything that's owned by friends and family, fair market value for rent or services. I won't go into a lot of detail on this because we have covered this in our other presentation, but just again reiterating that CMS is, well, the government is saying, we just want you to be able to treat the patients and get them well and stay safe yourself. All right. So if the facility is offering to pay for extra meals or laundry or childcare while the providers are there, that's been waived. You know, group practice restrictions, and also have been waived so that one physician can order items for another partner's patients. Radiological or lab services, if the physician rents, you know, has a mobile unit and rents a parking lot for a short time, they're not going to be looking into how much rent you're paying for that. And then if a physician contracts out to be a supervising physician for to provide supervision to something like a home health agency, then the hospital can provide some continuing medical education units to bring that physician up to speed on new home health issues or and exceed the cap. So signature requirements are being flexed. I think there's like a 30-day window now. MIPS incentive submission deadline is now, they waived it out for 1 month. And then they've also waived any face-to-face requirements for a lot of the local, national and local coverage determinations. So that can now be through audio, video, and then they've also set up provider hotlines. Okay, and the physicians can provide services from their own home without having to update your paperwork at CMS to have the physician's home be the provider's office. So the physicians can also, and nurse practitioners can contract with auxiliary personnel to have those auxiliary personnel provide incident to services and then bill those under the physician. And then they've also relaxed, so hospital admissions now can be done by nurse practitioners. And they've also waived a lot of the requirements where so that the physician or nurse practitioner, et cetera, they no longer have to be licensed in the state where they're practicing, just as long as they are licensed in the state where they have Medicare coverage. All right, and then the frequency limits for the monthly hands-on visit can now be done through telehealth for end-stage renal disease, hospice, and inpatient rehab. And a big one is direct supervision can now be virtual. So that's an audio-visual presence. So as long as the person that's providing the service can get a hold of the doctor by audio-visual means during that performance of the service, that can be done. All right, so teaching physician supervision may also be virtual. There are some exceptions, and that has to do with operations and endoscopies. Residents may now moonlight in the inpatient setting like they could in the outpatient setting. And then the teaching physician can review and sign off on a service like an E&M at a later date. That teaching physician no longer has to be physically present during the performance of those. And the homebound definition has been broadened so that if the doctor says that this patient has contraindications and should not be going out in public, that will qualify them to be homebound, as well as if they've been exposed or have the COVID-19 virus. And another big one is that a lot of the services no longer need to, where it says established patient for some of the telehealth and the telephone services, the patient does not need to be an established patient. It can be a new patient. All right. Telehealth has had updates to the codes that are on the list of approved services. There have been some provider updates for some of the services, which has added to the confusion because physical therapy services have been added as approved, but the therapists that provide those, like your physical, occupational, and speech language pathologists, they were not added as approved distant site practitioners. And then evaluation and management, the code selection can be based on time or medical decision making, and that does not have to have history and exam as a component. And audiovisual may take the place of a face-to-face component. All right, so one thing that helps to understand about telehealth services is that for a telehealth service, there has to be audio-visual contact. And so these online service or e-visits, these are not considered telehealth because they are not audio-visual. Now these have been added. It was a bit confusing in the interim final rule that was published because they kind of went from telehealth into the online visits and e-visits, and they seem to be, they seem to run together. But the online digital evaluation and management service, the 99421 through the 99423 is, because it says evaluation and management can only be provided by those providers that can do an evaluation and management service, which is your physicians, your advanced registered nurse practitioners, and your physician assistants, where if you have your other qualified clinical staff, and this would be your physical therapists, occupational therapists, your clinical social workers, your psychologists, they can provide the 98970 through 72 or the G2061 through 263 or G2063. And the flexibility on on these services is that the patient does not need to be does not need to be an established patient. And so the G2010 is an online service, and this can be something where, you know, maybe you have taken a picture of a wound and sent it to the doctor's office to be evaluated, for them to get back to you to maybe say, okay, no, we need to come in and see you, or we need to get you a different prescription. And then the G2012 is a virtual check-in, which is also through a portal. And so you can, the patient could write in, to their cardiologist, hey, I'm having some shortness of breath. My, this is my blood pressure reading for the last couple of days. And I'm starting to have some, my feet are starting to swell. And then that can be evaluated by the practitioner and responded to. All right, so telephone services. Now the 99441 and the 443 can be done by the physician, ARNPs, PAs, because it says evaluation and management. The 98966 through the 68 is for your clinical staff that can do an assessment. And these are newly approved. And this is where there is just telephone contact. There is no face-to-face, but it's audio only, no video, so it does not qualify to be telehealth. So just kind of remember that these would more than likely, since the provider would normally provide these in the office, you would use the place of service 11 to report these. All right, so just to remember, is the service telehealth? Does it have audio video? If so, then it's yes. So then you would use the place of service that would occur if we weren't having the pandemic. So if you would normally see that patient via telehealth, you would be billing telehealth. But if you would normally see that patient in your office, then you would bill that in your with a place of service office, and that would be even if the physician or the patient or both are in their own respective homes. Now, if that patient happens to be somewhere else, like a skilled nursing facility, then you did this via audiovisual, then you can use the skilled nursing facility place of service. All right, now if you have a telehealth service, so you have an evaluation and management service where both the patient was at home and the physician were at home, you could report like your 99213 with modifier 95. Now, if you are a critical access hospital doing your method 2 billing, there is a change and you would report modifier GT. And then there are some, if you're doing if you have a telehealth service that you're doing for a patient who's had a stroke, then there is the G0 modifier. And CMS has said that you do not need to report the disaster-related modifier CR on these claims. So CMS has stated that the telehealth services, they consider those to be professional-only services. So if the patient is not at a facility, there is no originating site fee, which is at Q3014. So unfortunately, there would be nothing for the facility to report on the UB claim. But CMS is taking that under consideration. So they're kind of winking broadly that there will be a change. We just have not seen any guidance yet on that. All right, so who can provide evaluation and management services? I've got those listed here on the left side. And who may not provide E&M services, I have listed on the right side. And so when you're taking a look at some of those telephone services, that can be the differentiator between who can provide which service. All right, so unfortunately, the physical, occupational, and speech therapists are not approved distant site practitioners, but they are approved to be able to provide some of those telephone services. And since CMS is saying they're professional, that means it has to be submitted on the 1500. But although they are hinting at changes, we have no guidance yet. All right, so audio, visual, telehealth. Audio is telephone, and that is not telehealth. So, older patients who may not, or if you have really poor internet and you're doing telephone only, that would be your telephone service. And then another scenario that has come up is if you have a physician and a patient, they're in the same facility, but they're not face-to-face. You can bill that, but it is not considered a telehealth service. So if you have a patient who comes in and they're, they're quarantined, or on one of the last calls, they said the patient came in and saw the physician, but they called a specialist that was over in on the main campus and did the audio video. That the specialist was still able to bill as a face-to-face service, because they've relaxed that component for now to say that the audio video can stand in as a face-to-face service. All right, so for telehealth, your 1500 is going to need your CPT HCPCS code, your place of service, which you can report the place of service 11 for office, and that's not the only one that can be used. And then your modifier 95, possibly the CS if this is relating to the COVID ordering of the test. You do not need to use modifier CR, and you would use that place of service where they would normally see the provider, and the patient and the provider are not in the same place. All right, so some of the expanded services that have been added to the telehealth services I've listed here. So you've got emergency department, home visits, care planning, psych and neuropsych testing, your therapy services, but they would have to be provided by the physician. And then a big change also is your E&M code selection can be based on time or medical decision making, and that the time is to include all of the time on the date of the encounter. You are not required to use history or exam, and CMS has kind of said you can either use the time from what was published in the calendar year 2020 Medicare Physician Final Rule, because this is kind of a change that we'll see coming for 2021 code selection, or you can use what's in the current code descriptor. And at this time, CMS is not, they're not changing the definition of medical decision making. So, so it's still your low, straightforward, etc. Excuse me. And so for your E&Ms, I did go out and get the median times. This is only for codes 99201 through 99205. It does not count towards nursing home visits, unfortunately. So you could either use the median time listed here or the time in the CPT code descriptor itself. So where it says, you know, typical time is 15 minutes, you can use that code. All right. And then I think the last slide starts our references. And so, Julie, I believe we are ready to start taking questions.
Yes,
All
we have
right.
lots and lots of references there that you guys will get. There's a lot of information on this, so don't feel like you have to write that down.
Right, and we will be, as we stated earlier, we will be providing everyone on this webinar with an email that has a copy of today's presentation, a link to the live recording, and all of an FAQ document, including all of the questions with answers provided throughout today's session. So with that being said, first of all, great job again, ladies. And no, Jennifer, we are never sick of hearing your voice ever. Neither you, Ardith. We always love your expertise. So great job as always. All right, first question. CS modifier. What does this all apply to besides E&M? Do we apply to the COVID test itself?
Well, CMS actually answered that one yesterday, and you certainly could on that, but laboratory testing normally doesn't have any cost sharing, so it's one of those, yeah, you can put it on, but it shouldn't impact anything one way or another. So yes, definitely you can put it on your COVID testing. The question is around all of the other stuff, right? What if your physician orders a chest x-ray, for example, in order to determine whether or not you need COVID testing? That's where we've got the questions. You know, what if your physician orders other coronavirus testing that's not COVID, or influenza testing? Does it go on that? And those are the things that we, as Ardith said, there's usually no cost sharing on the lab anyway, but do we put the modifier there or not? We hope to clarify that within the next couple of days.
Okay. Another question that, sorry about that. Another question that came in, Ardith, the second part of the presentation, which was your piece, was that specifically physicians?
Yes.
Okay. All right. We had that question, so I wanted to make sure that we answered that. Yes, the second half of the presentation was focused on physicians.
Yeah, I think the only difference was the DR condition code, and then because that would only be on outpatient facility claims, and then the CR modifier, which would be used by both outpatient hospitals and physicians.
Okay, perfect. All right, can you please go back over the use of Q3014?
Yeah, unfortunately, like I said, right now, the definition of Q3014 is that the patient has to be in your facility. So that kind of rules out using that if the patient is remote and say the physician is in your facility providing telehealth. Right now, that definition is what it is. It can't be changed. And so right now, you're going to use that Q3014 when the patient is present in your facility. So maybe the physician is off in his office and you've got an inpatient there that needs services. You can bill that Q3014. Or if the patient is in your emergency room and the physician is remote, then that Q3014 would be appropriate for the facility to bill.
Excuse me.
Okay. Okay, great. What date does the waiver on the 3-day rule regarding transfer to SNF start?
All of the waivers are start with the date that the public health emergency was declared. Ardith, do you have that exact date?
I will double check, but most of those, I believe, are March 1st.
March 1st, yeah.
Okay.
Perfect.
And do they apply for all patients or just for the patients with COVID-19?
No, the waivers are for all patients. So if you have even a psychiatric patient that has to be moved into a different unit of the hospital because maybe you're making that unit COVID, that would still apply even though the psychiatric patient does not have COVID. That's why just make sure that you're documenting all of that, that you're not just doing anything for the fun of it, but that there is a need to do that in order to provide the most efficient care and to expand your facility's capacity as much as possible.
Okay. Should CS be reported on commercial as well?
Yes, that is an indicator to those that commercial insurance, that they need to be waiving that cost sharing, and that is covered in the CARES Act. No, excuse me, the Family First Response
Get all
Act.
of these rules
Yeah,
right.
I know. But yes, when they are talking about the cost, waiving the cost sharings, group health plans are have to abide by this. So do the Medicaids and also Indian Health Services, TRICARE. So they were used a pretty broad brushstroke to cover all payers.
Okay. All right. For inpatient, if the patient does not have COVID, should we be adding DR due to the possibility of meeting one of the waivers? How do we know?
How do we know whether or not it's going to qualify for the DR care? If that patient has nothing to do with COVID, I wouldn't put that that code on there. But remember that it, even if, let's say the patient is in your hospital with pneumonia and it takes a little, you don't really know whether or not they have COVID. Because it takes maybe a little while for the test to get back, and they end up testing negative for that and say positive for influenza or something. In that case, that was essentially COVID-related care, and I would use that condition code. So it's a bit of a fine line. Did you have anything to add to that, Ardith?
No, because I think what we said was before was that it is a fine line, and if absolutely nothing in that patient's care was impacted by the disaster, then you would not use it. But if they had to go to a different floor because you have a COVID unit and a non-COVID unit, then you would. So it's going to be very situational.
That's a good point. Thank you. Yes.
All right. When teaching physician conduct supervision, can they use audio only, or do they have to use video and audio?
In the waiver, it does say audio video, but when they're providing the supervision, but I will go back and recheck just to make sure they haven't changed anything on me in the meantime.
Okay. Sounds great. Which most likely we're going to have to go back and check before we provide all of these questions and answers, because as Jennifer stated earlier, it's changing on the daily. So we want to make sure we get you the most up-to-date information. All right. My understanding from the IFR is only the outpatient visit codes 99201 through 99215 can be coded based on time or MDM.
Yes, that's true.
Okay.
They do specifically state that it is the office E&M visits, the 99201 through 9920215. And what they're trying to do is kind of broaden so that it kind of mirrors what is going to be coming into place for 2021. And so that's where the time does not need to be based on counseling and coordination of care. It can be solely based on time or medical decision making. There's no reference that you have to document, absolute start and stop times. Just that make sure you're documenting the time, and it's all time on that day. So if you're working with the patient and you spend, 5 minutes here, 10 minutes there, another 10 minutes later, you can combine all of that into an aggregate and report based on that time.
Okay, great. Can you please explain the difference between a virtual check-in and an e-visit?
Well, they're pretty much the same. It's the same kind of technology for the same kind of, it's the same verbiage for this same thing.
Okay.
Sorry, I stumbled on that. Isn't it? They're cinnamon. They're synonyms. Synonyms.
If a provider is coding based on total time spent with the patient, should they note the amount of time spent within the visit progress notes?
That would be very helpful. And remember, it also covers some of the other times that does not necessarily need to be spent with the patient, you know, like kind of reviewing some notes, checking to see what their test results are, that kind of thing. But what you want to do is make sure that the documentation is strong enough where if there's an audit that needs to be done, that you're able to support your documentation with that.
Okay. Regarding the telehealth modifiers, for critical access hospitals, should we always use the GT?
Yes, that's the one that's been signaled out for use for the critical access hospitals.
Okay, great. Can you please provide some guidance on billing the antibody plasma? What HCPCS for the produce, and is blood admin 36430 correct?
Oh, I might need some help with that question. The antibody testing are the new codes, the 86328 and the 86769. Those are both performed at the current time using serum or blood plasma. I'm not exactly sure what a transfusion would have to do with that right now, which is the 36430. Yeah, we might, I don't, if you ask that question, we might need some clarifying information in that.
Okay. All right.
Did they say convalescent plasma?
No, they said expand on the antibody
Okay, all right.
plasma.
Oh, so maybe they are talking about the plasma administration, you think?
That's what I'm wondering about, because there are now some clinical trials out there for convalescent plasma. But the convalescent plasma has been, is now an investigational by the FDA. And so to be able to work under that, you would have to be part of the clinical trials. And so you need to make sure that you sign up for those.
Okay.
Yeah. And so since you can bill for the routine care things, then there are some specific guidelines that would need to be followed with the, like reporting the 36430.
Okay. All right. So the person that asked that question, if you would like additional information, go ahead and enter a little bit more in the panel, and we'll attempt to get to it today live. If not, again, I want to reiterate, if we don't get to all of your questions live today, we will be taking them all in, creating an FAQ with the answers for everyone's questions that you submitted throughout today's presentation. All right, we're going to go ahead and take a couple more questions. We do have about 5 more minutes until the end of the hour, and we want to be sensitive to everyone's time. So probably 2 to 3 more questions, and then we'll wrap it up. How do I bill a new admission to SNF that was done by telehealth to Medicare?
A new admission to SNF that was done via tele. Well, and that's going to be the physician doing that.
Right. So there should be no change.
No difference, yeah.
Just make sure you're using modifier 95 on the E&M code. And then for the SNF, they have some flexibilities on how soon they have to get the, is it the OASIS
That's, yeah, all of
documentation in?
Yes, that's true too.
Okay. Are you applying CR and CS to 87635 and U0003?
Again, the CS, there really shouldn't be much cost sharing, but I would, yes, go ahead and put that in there. And the CR would signify that, yeah, that is COVID related. So, yes,
Okay.
I would.
All right. What place of service code should be used for Q3014 when the patient is admitted and the physician is home?
Well, the Q3014 is a facility charge, and therefore facilities don't use place of service.
All right. Here's kind of a multi question one, and I think this is probably going to be our last one, and then we'll wrap it up. Many of our COVID inpatients are receiving very expensive medications. I have two questions. The first one, will these med charges only go towards the outlier amount?
Yeah, pretty much. We're not having much change. They're not changing the grouping. They haven't added any special payment to any of the different drugs. So what you are going to get for that is that 20% boost in the DRG weight that's going to be figured by the max. And then, yes, also if your account qualifies for outlier payment, then you would get that as well.
Okay. And then the second part of the question is, how do you recommend handling oral meds that would more typically be considered self-administered meds because they are oral liquids or tablets? Can you recommend any different revenue codes or HCPCS codes other than 637 and A9270, which will cause the patients to be responsible for these charges?
There shouldn't be any change to the way you handle your oral meds. So if you're talking an inpatient, I would report it under the 250 and it will roll up to your DRG. And if you're talking outpatient, yeah, I would still be doing whatever your facilities, because not all facilities bill that 637 for the reason they were talking about, that it is going to give some patient responsibility or require that they bill those to their Part D coverage if they have any. I wouldn't change anything on how you handle your oral meds now for this particular pandemic.
Okay. All right. Well, again, we want to be sensitive to everyone's time, so we're going to go ahead and wrap up the webinar. Always, thank you, Jennifer. Thank you, Ardith. Such a wealth of knowledge. We all know that this is such a hot topic right now. We're living in this unprecedented world and time, so this is definitely very, very great information to have. I do want to say that we'll be sending each of you a link to complete a very short survey. It's only 3 questions once we wrap the session. We ask that you please take 2 minutes to complete the survey. This is the only way we're able to measure the effectiveness of the content we present, as well as provide us with some guidance on future content. So it's very important, please, and thank you in advance for completing the survey. As mentioned earlier, one more time, we will be sending an email within 5 business days, but I'm hopeful we can get to it earlier with an FAQ document of all of the questions with their answers submitted throughout today's session, as well as a copy of today's presentation and a link to the live recording. If you'd like more information, or you forgot to submit a question during today's webinar, or something pops up in the next couple days, please feel free to email me directly at events@vitalware.com, and we'll definitely get that routed to the correct person to get the correct answer. Make sure you visit us on future VitalWare webinars. You can find those on our website under the reference tab. You can register right there. Make sure you follow us on our LinkedIn page. Just stay connected. So once again, thank you all for joining us today. We hope you have a fantastic rest of your afternoon. And again, thank you, Jennifer and Ardith.
Thank you.
Thank you.
Right. Bye.
Bye.
Thanks. Bye-bye.